Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Dr. Sara Collins, thank you so much for joining me today to talk about the Commonwealth Fund state scorecard on women's health and reproductive care. Before we jump into the details of the scorecard, though, I think it might be helpful for you to introduce the Commonwealth Fund to our audience.
Well, the Commonwealth Fund is a nonprofit, nonpartisan healthcare foundation. We support independent research on healthcare issues and make grants to promote better access, improve quality, and greater efficiency in healthcare, particularly for society's most vulnerable, including people of color, people with low income, and those who are uninsured.
So the Commonwealth Fund is known for these in-depth reviews of data in different areas, sometimes comparing the United States health system with others, sometimes within the United States health system. This report starts with this sentence: the health of women in the United States is in a perilous place. Could you talk about the origins of this report?
Yeah, the Commonwealth Fund's health system state scorecards use the latest data available to assess how well the healthcare system is working in every state. Since 2007, 2007 was our first state scorecard. We've been producing these state scorecards nearly annually, and also we produce special focus scorecards in areas of high policy interest, such as racial and ethnic disparities. This first women's health scorecard is based on 32 measures of how state health systems are performing for women in all 50 states and the District of Columbia. The reason that we decided to focus in this area is that state policy actions before and since the 2022 Supreme Court overturn of Roe v. Wade are changing the way that women can access and use healthcare, raising concerns about their future of their healthcare. So in this study, we asked the question, how do health outcomes and access to reproductive care differ across the states? We collected the data, or the scorecard data were collected in 2022. So these are the latest federal data in the areas of interest. And this is the same year as the Supreme Court decision overturning Roe, and provide an important baseline to assess the future impact of policy changes resulting from the ruling.
So you are looking to assess the health system in each state with respect to women's health. What are the measures you apply for that in this scorecard?
We look at areas of healthcare quality, healthcare access meaning insurance coverage primarily, women that state that they have a usual healthcare provider, whether or not they've had cost-related issues accessing healthcare. And we also look at prevention. The rates, for example, of cervical cancer screenings are in each state, and mammograms. So we look at all three of those areas: outcomes, access, and prevention, and then rank the states based on measures within those domains on how well they perform relative to each other.
So it sounds to me like the changes in reproductive healthcare access triggered by the court decisions might have spurred the Commonwealth Fund to look at women's health this year for your scorecard, but your look at women's health was pretty broad.
That's right. So we look at all-cause mortality for women of reproductive age. We did focus on women of reproductive age in particular, but we also look across the age spectrum, particularly in areas of prevention. But because of the policy interest in this age group, what effect is that decision going to have on women's health and reproductive care, and what policy decisions predating Roe were also important in what we're seeing right now, and give us a sense, maybe foreshadow what we might see in the future. Insurance coverage, policy decisions that states have made on insurance coverage predate the decision, but are very important in how state health systems are performing for women.
So help me understand this. You said how many measures total were you looking at?
32 measures.
How do you take 32 measures and turn that into a scorecard that isn't just like a big table with 50, rows and 32 columns?
We use something called Z-scores, where we look at differences in performance metrics. A state's standardized Z-score is calculated, if you want to get into the details, by subtracting the 51 state average from the state's observed rate and then dividing by the standard deviation of all observed state rates. So state standardized Z-scores are then averaged across all the indicators within the performance dimension that I mentioned: quality, prevention, access. And dimension scores are averaged into an overall score, and ranks are assigned based on the overall score. This approach gives each dimension equal weight, and within each dimension, it weights all indicators equally. This method accommodates the different scales used across the scorecard. Indicators, for example, percentages and population-based rates. This is a standard approach for all our state scorecards. I will recognize my co-author and senior scientist who leads all this work, David Radley. He is the brain behind the methodology and the scorecard and has been engaged in the scorecards since 2007.
Got it. If I had known we'd be talking about Z-scores, I might have had a better breakfast this morning. But your explanation was extremely good. It was one of the clearest explanations that I have heard. You're really looking at how states compare to other states in each of these dimensions within each category. And that allows you to get a more general sense of whether a state's doing better or worse than others.
And the overall goal of these scorecards is to look across the states and how well they're performing, and to look at where states might be able to improve. Our hope is that the scorecards will be used as tools by states to look at where they're weak, where they're strong, where they might make some changes in their delivery systems or in their policy decisions, like that have to do with insurance coverage, for example.
You organize the states into 4 groups: top performing states, better than average, worse than average, bottom performing states. I think we've gone long enough in this podcast without naming some of the star performers and some of the states struggling.
That's right. So what we find really with this scorecard are that women's health is in a fragile place, with healthcare systems in many states that are struggling to provide comprehensive healthcare to women across their lifespan. And we are seeing really a deep and likely growing geographic divide in women's ability to access vital health services and maintain their health, particularly among women of reproductive age. And I'll just hit a few highlights here. Deaths among women of reproductive age, these are all-cause mortality, are highest in the southeastern states. Causes of death include many that are preventable and treatable with adequate health care, like maternal mortality and cervical cancer. Rates of maternal deaths are highest in the Mississippi Delta region, which includes Arkansas, Louisiana, Mississippi, and Tennessee. All 4 states had abortion restrictions prior to the 2022 Supreme Court decision overturning Roe, and they now all have full abortion bans. A substantial percentage of counties in these states don't have a single hospital or birthing center with providers that provide obstetric care. And women's inability to afford needed health care of all kinds is most pronounced in states that have not expanded their Medicaid programs. Just in terms of the rankings, the top 3 performers, Massachusetts, Vermont, and Rhode Island. The bottom 3 performers, Oklahoma, Texas, and Mississippi.
The data paint a very concerning picture if you think that the states, even before the Dobbs decision overturning Roe versus Wade, really were doing the worst on your measures, generally speaking. And the concern then would be that the divides will even grow wider.
That's right. And when you look across the rankings, all the states, or nearly all the states with abortion bans, and then another major indicator without Medicaid expansion, so the 10 states that have not expanded Medicaid under the Affordable Care Act, are in the bottom half of the states in terms of health system performance. So this was in 2022. This was prior to the Supreme Court decision overturning Roe. And we're already seeing evidence in other research that are showing the effects of the decision on providers, health system capacity, women's ability to access reproductive healthcare services, access care when they're pregnant and throughout their pregnancy. In many states was really at risk prior to the decision. And what we're seeing play out since the decision in terms of medical residency applications are down in all states, but they're down the furthest in states that have abortion bans or limits on abortion. We're also seeing a decline, healthcare centers going out of business in these states, just not being able to provide the services they were prior to the decision. So this should be of major concern to health system leaders in the states, policymakers in these states that are already struggling pre-Roe to provide adequate care to women who are pregnant or women who are in need of reproductive health care services. And the other concerning aspect of this, in terms of the medical residency application drop-offs in these states, is that these drop-offs are not only in women's reproductive care, OBGYN, but also in other specialties. And so states really, this is a red flag for states and an alarm for states that are maybe already be struggling to have adequate provider capacity in their health systems.
Anything surprise you when you sat down and did this report looking at the state of women's health care in the United States?
Really, the biggest surprise is this deep geographic divide in women's health outcomes, deep differences in access to vital health services, stark regional and ethnic divides in health outcomes. And I think also the degree to which policy decisions have contributed to these divides. I think some of this is some of what we're finding on breast and cervical cancer screenings, on other dimensions of prevention, postpartum depression screening. What's played out in the data in terms of outcomes, and I'll speak to the latter, postpartum depression screening, that states generally that have higher rates of postpartum depression screening, and this is important because the majority of maternal deaths, pregnancy-related deaths, occur post-pregnancy, so in that postpartum period. And the majority of those deaths have underlying mental health causes. So it's deeply important for states to be conscious of screening for postpartum depression because of these factors. And what we see in the data are states that do have higher rates of postpartum depression screening also have lower rates of postpartum depression reports by women. So this is an area that makes sense in terms of what we know about the research. And states that are not doing this adequately are actually seeing higher rates of postpartum depression.
Yeah, what's jumping out to me about this conversation is that a clear and citing reason to do a report like this was the earthquake that was the overturning of Roe versus Wade, and was grounded in abortion access. But what you're finding is far broader than that. Is that fair to say?
That's exactly right. And I think that it's illuminating when you look at the maps. So when you look at the maps of the New York Times, for example, has a map on abortion bans. And the states with abortion bans are all concentrated in this southeastern region. I mean, there's dispersion across the country, but really in the southeastern part of the country, the Delta, Mississippi Delta. And then you look at the other maps in the report, postpartum depression screening, and all-cause mortality among women of reproductive age. And those same states show up red or the deepest color on our maps, showing that systems are not performing well for women consistently across most of the measures in our report. And it just raises a lot of concerns going forward. Are we going to be a country where women just have fewer access both to insurance coverage, to reproductive health care services, where they're not getting good preventive care in certain parts of the country and much better in other parts of the country? And is the Supreme Court decision to overturn Roe just going to exacerbate what we're already seeing pretty clearly in the scorecard?
Do You think the Commonwealth Fund will update this scorecard, after at least a few years have gone by after the decision, to see whether that concern you have is actually borne out?
Absolutely. These can be considered baseline data. Like I said, most of the data date to 2022, which is the same year of the Supreme Court decision. And we will revisit these measures over the next couple of years to look at how that decision is playing out across the states.
Dr. Sara Collins, thank you so much for doing this work. We'll link to it in our show notes and for this great conversation.
Thank you so much, Josh. I really enjoyed it.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production management by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Eliza Rosen. If you have questions or ideas for us, please send us an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.